Okay, yeah, thank you. I'm going to say a warm welcome to all of the participants of this webinar. And before I start, and this is on behalf of both the North Thames and the South Thames Pediatric Networks, I have to say a huge thank you to Erogen, who have sponsored the webinars for this month. And a huge thank you to Kathy and Heather for coming to talk about this amazing work that they have done for NCEPOD. So I'm going to hand over to you, Heather.
Okay, and I'd also just like to say thank you for inviting us to present the results of the report today. It's really exciting. It feels like it's taken a long time to get to this point. So I am just going to begin by giving you a background to the study, why we did it, how we did it. Then I'm going to come on to talk about some of the big data that came out of the report, and then I'll hand over to Kathy. So the number of people receiving LTV in the UK wasn't known. There had been limited local or national data collection, and that wasn't helped by the fact that there was no national procedure code. Where research had been undertaken, it had shown a significant increase in the number of children and young people receiving LTV over the last 30 years. We were looking at a really complex group of patients. So there's variation in underlying diagnosis. We're looking at a group that ranges from small premature babies who require support for their developing respiratory and airway systems, to a group of older children and young adults who require support for their failing respiratory and neuromuscular function. And this group of patients often also has multiple comorbidities. However, we are seeing more and more an increased survival rate. So there are more and more children moving into adult services. So that is going to have an impact on transition. And that's something that Kathy will come on to talk about later in the presentation. There's also variation in the type of ventilator support that's required. So again, we're looking at a group of patients who might require non-invasive ventilation overnight only, to the more severe end of the spectrum where patients require tracheostomy ventilation 24 hours a day. And finally, there's also been shown to be variation in the provision of care outside of the hospital setting. So taking all of this together, what we were looking at is a really complex care pathway. And there's the opportunity for delay to occur at all points in that pathway. And again, where delay does occur, it just shows that the needs of parents, their patients and families aren't being met. So at the start of every study, we put together a study advisory group. We write to all the colleges, associations, faculties, charities, organisations who are working in the area of care that we're looking at. And we ask them to nominate a representative to sit on the study advisory group. And the main role of this group is to help us form the aims, objectives and methods. So the aim of this study was to identify remediable factors in the care provided to people who were receiving or who had received long-term ventilation up to their 25th birthday over a 2-year period from the 1st of April 2016 to the 31st of March 2018. In terms of a definition, we were using the fairly standard definition of ventilation that is provided every day for 3 months or more, and where the intention was to carry on that ventilation at home. We wanted to include both invasively and non-invasively ventilated patients in the sample, and we wanted to look at care across the whole pathway, so at the point of initiation, at the point of an acute admission to hospital, and also in the community. To do this, we needed to collect data from a number of different sources, and I'm just going to talk through each of those in a bit more detail now. So the first thing that we needed to do was to identify the number of children and young people who were receiving LTV during the study period. And we always knew it was going to be tricky because there is no OPCS code. There was going to be no easy way for us to identify them. So to help us with this, we set up a study contact in each hospital, sometimes multiple study contacts, and we asked them to report to us the details of all patients who were either under the care of their LTV service or who were admitted to their hospital over the 2-year data collection period. So that gave us an idea of the total number of people, children and young people across the UK receiving LTV. What we wanted to do from that big group was to sample a much smaller group for inclusion in the clinical peer review process. And we were aiming to look at the care of around 500 patients in more detail. We wanted to split this group into two. We wanted to look at a group of patients who were already established on LTV, and we wanted to look at a second group of people who underwent a new tracheostomy insertion during the 2-year period. So the established group was always going to be the bigger group, and we were aiming to look at the care of about 400 patients. For each of these patients, we sent out a lead clinician questionnaire, and that went to a member of the team who was responsible for providing the ongoing hospital-based care of the patient, and a community team clinical questionnaire, and that went to a member of the community team who was responsible for providing the community care for that patient where we could identify them. We then subdivided that established group into 2 smaller groups. We were aiming for about half who had had an acute admission to hospital during the study period, and the other half who hadn't had an admission. Where the patient had had an admission, the clinician who was responsible for the patient at that time of admission was sent the acute admission questionnaire to complete, and they were asked to return that alongside copied extracts of the case notes. So for each study that we undertake, we set up a group of case reviewers. Again, we advertise this widely, and we make sure that when we're recruiting, we get a good mix of specialties from within the area of care that we're looking at. We also make sure that we've got good representation from around the UK and also from the different types of hospital that might be involved in providing care to that group of patients. So for the LTV study, the case note review process was very much focused on the acute admission pathway. The second group of patients that we wanted to look at were those who underwent a new tracheostomy insertion during the 2-year period. And we did have discussions with the study advisory group about the best way to explore the care at this point in time. However, it was felt the things that we wanted to look at, which were primarily around decision making and the consent process, we wouldn't be able to easily get that information from the case notes that we were getting back in. And so for this group of patients, we sent out the tracheostomy insertion questionnaire. So that's the clinical data collection side of things. We also had a number of different other data collection methods to supplement this data. So we also collected organisational data. We sent an organisational questionnaire out to all hospitals who had notified us of patients for inclusion in the study. And that basically gave us an idea of the facilities and services that were available within each hospital. We know that services often differ between paediatrics and adults. So we basically split the questionnaire in half and asked the same questions in each half, one for paediatrics and one for adults. So we'd be able to get both sides of the story, or both pieces of the picture. We also wanted to collect patient and parent care reviews on the services that they are able to access, and we did this using 2 methods. So we had an online survey that was completed by a large number of people, and that was supplemented with a smaller number of more in-depth focus group interviews. And this is something that we mirrored for health and social care professionals. So again, we wanted to get an idea of the services that they are able to provide. We did this, again, using an online survey where we had a large number of respondents, and we supplemented that with more in-depth clinician interviews. So where does that leave us in terms of numbers? Over the 2-year period, we were reported the details of 3,738 children and young people who were identified as receiving LTV. However, there was the opportunity that patients, children and young people could be reported to us from multiple locations. For example, if they had an admission to one hospital, they have their ongoing hospital-based care provided by another hospital. And we'd also been sent a copy of the community team spreadsheet back as well. So once you account for that and the patients who were subsequently excluded as the study progressed, we identified 3,061 people who were on LTV between the 1st of April 2016 and the 31st of March 2018. And actually, I think it's just worth flagging up here that we think this is likely to be an underestimate. We know that we won't have been reported every case from every hospital because of the difficulties in identifying patients. And we also know that there are a small number of trusts or health boards who are unable to send us any data. So just to give you an overview of the demographics of this big group of patients, in terms of age and gender, 60% of the sample were male with an average age of 12 and 40% of the sample female with an average age of 11. We asked about the type of ventilation that young people were receiving, both at initiation and at the end of the study period. At initiation, 21% of patients were initiated on invasive ventilation and 76% of patients on non-invasive ventilation. And actually, we've done some further research subsequently, and we've seen there's very little change over the 2-year period. The biggest change is probably in the group of patients who were classified as other, and actually where we were able to look at some of the free text data that had come back, that generally was as a result of decannulation or death. Over the last few months, we have undertaken some further work looking at this group of patients in a bit more detail, and we have put together a paper which we've now submitted to the Archives of Diseases in Childhood. So this slide here isn't for sharing today. It's additional data that wasn't included in the report, and we're hoping that it will be published at some point this year, or at some point. But just to flag up that it's not been peer reviewed in quite the same way yet. But we were able to look at the age of the patient at the time of initiation by the type of ventilation that patients were initiated on. And if we look at the group of patients who were initiated on invasive ventilation, the average age of patients in this group was 3, with a median of less than 1 year. And within the group of patients who were initiated on non-invasive ventilation, the average age of the patient was 9, with a median age of 8. If you look at this, if you take this population as a whole, 30% of patients were initiated before the age of 2. If you look at just the patients who were initiated on invasive ventilation, that figure increases to 66% of patients being initiated before the age of 2. We also asked study contacts to give us an idea of the underlying condition, so the reason as to why patients had been put on long-term ventilation. We got lots of free text data back that we were able to group into 4 broad categories. So if we just look at the right-hand side of the screen first, the NCEPOD data. Within the group of patients with an upper airway obstruction, the most common conditions were obstructive sleep apnea and Down syndrome. Within the group of patients with a musculoskeletal disorder, the most common conditions were muscular dystrophy and muscular atrophy. Within the group of patients with a disorder of the central nervous system, the most common conditions were cerebral palsy or CHS. And in the group of patients with a chronic respiratory disease, the most common reason for requiring LTV was as a result of prematurity. Males, as you probably would expect, predominated in each of these groups. However, this was especially the case for patients in the group of patients with an upper airway obstruction or musculoskeletal disorder. And there was also variation in the average age within each of these groups, with the lowest chronic respiratory disease, where patients had an average age of 7 years, up to those patients within the musculoskeletal disorders group, where the average age was 14. Again, we have done some further work. We've pulled all this data into a combined table with some of the previous research, so we've been able to look to see whether there have been any changes. You can see from this table now, the biggest decrease has been in the group of patients with the musculoskeletal disorder. So between 2010 and 2020, that percentage has fallen from 43% to 29%. And the biggest increase has been in the group of patients with a disorder of the central nervous system, which has increased from 18% to just under 25%. And within the NCEPOD data, this time we've seen a particular increase in the number of patients being reported with cerebral palsy. We also asked for details of the duration of daily ventilation. 75% of patients were ventilated overnight or overnight another, and that other tended to account for nap time. Within the group of patients who were ventilated for 24 hours a day, 74% were on non-invasive invasive ventilation, and in the group of patients who were ventilated overnight, 87% of that group were receiving non-invasive ventilation. Finally, we asked whether patients had an admission to hospital during the study period. That was something that we were later sampling on, and 57% of patients had an admission to hospital during the study period. So I just want to finish on this slide, and in particular, the top right-hand corner of this. So as I've said, we sampled 3,061 patients in total on LTV. We wanted to sample a smaller number for inclusion in the clinical peer review process, and we were aiming to look at the care of about 500 patients in more depth. However, we sampled slightly fewer than this, so we picked up 392 patients on the established LTV pathway, of which 231 had an admission to hospital during the 2-year period, and we sampled 81 patients for inclusion on the new tracheostomy insertion pathway. And I just wanted to finish on this data because I'm going to hand over to Kathy now, and this is very much the data that she'll be picking up on for the remainder of the presentation, alongside any of the organisational data, some of the patient and parent carer data, and some of the health and social care professional data. So I will hand over to Kathy now, unless anyone has any questions on that first part of the presentation.
Francois, I think it's you who's raised your hand.
Just a quick question. Do you know why there's such a reduction in the neuromuscular patient?
Francois, can I just ask you to turn on your camera if possible, so we can?
Yes, of course.
The team can see you speaking. No worries.
Hello. I was just wanted to ask about why do you think there's a reduction in the neuromuscular patient? Because that's obviously there's variation between centers, but that's not been my experience. So I'm a bit curious about that.
Can you hear me now?
Yes. Yeah.
Hi, Francois. Hi, everybody. The absolute number of patients has gone up. It's the relative percentage that's gone down in the overall picture.
All right. Okay. I see what you mean.
So obviously we're presenting big data here. So it is interesting.
So it may be because we've increased a lot more in the other categories like cerebral palsy, and as a consequence, the proportion of neuromuscular is less. Is that what you're saying? Okay.
But we can postulate. There's plenty of information about how maybe the biggest group within the musculoskeletal are the Duchenne, and we've probably delayed in the last 10, 15 years the point of time where they might be requiring LTV to slightly older years because of new treatments. What was interesting was that we didn't see any reduction in the numbers of spinal muscular atrophy in terms of, there doesn't seem to have been a downturn in that as yet, but we know there are new therapies there as well, which may make a difference. So those are just sort of postulates, if you like, Francois.
Yeah, thank you. Thank you.
Thank you, Kathy. I don't see anybody else's hand up, so I'm just wondering if you want to get on with the second half of the presentation.
Sure.
Yeah, thank you.
Great. Thank you again to the Pantems group for the invitation. Heather and I are really pleased to present to you today. We just before lockdown, the report was published in early March, and we managed 2 live presentations, one in Birmingham to a group of paediatric physiotherapists, their national meeting, and also to the Yorkshire network the day after. And then all the presentations that were planned in meetings thereafter, of course, have been either shelved or deferred, but thankfully yourselves have got going and are doing this amazing set of lectures online. We're really pleased to be here. So Heather's given you a flavour of the amount of data there is in this report, and I hope some of you have had a chance to have a look at it. If not, please do go online. It's all free. The full report runs to about 100 pages. There's a short report. There's an infographic. There's various bits and pieces that you can get, and I'll refer to those again at the end. And as Heather has said, there's been this huge increase in LTV patients. You're all aware of that. You're all working in your LTV networks. And we do have data, which I think is really valuable. And Heather did that comparison towards the end of her presentation, which we've referred to the 2 papers from 97 and 2010, with sort of roughly 10-year gaps between them. And ours is conveniently another 10 years on. So we see the changes. Our age group, of course, goes up slightly higher. Both those previous ones went up to the age of 16. Ours goes up to the age of 24, which was deliberate because we wanted to capture what was happening after transition. And we know that this population has grown in part because of the success of neonatal and paediatric critical care. Also, our success in looking after some of the most challenging groups of patients with complex problems, and the technology has now become more portable, and there's a general acceptance that these things can be delivered at home. However, there are lots of challenges, and that's why it's important to have a look at the population in some detail, and I hope we've managed to capture a lot of that. So just going back again into some of this big data, at least a 3-fold increase in the last 10 years. 30% initiated on LTV under the age of 2. A large number either peri or post transition. A big challenge to adult colleagues. 16.3% requiring 24/7 ventilation. And as we said, an increase relatively in the number of patients who are being ventilated with underlying CNS conditions. And actually in the last paper from Wallace, cerebral palsy actually isn't mentioned. We used exactly the same categories as they did deliberately when we divvied it all up. But cerebral palsy isn't mentioned, and we know there have been big advances in that condition. I'll just refer you back to the first of our child health reports published March 2018, which was actually just on that topic of cerebral palsy, not on LTV, but on cerebral palsy. So results and recommendation, we tried to keep these as simple as possible, not reinvent the wheel. There's some amazing ones out there. The West Midlands ones were revised in only 2018. So during the period we were collecting data, and we've been in continued contact with them, and we're incredibly pleased that they agreed to make the last set of quality standards free to view by everybody. So there's no firewall there anymore. You probably all know that, but we felt that was a big sort of easy win. And when the group were approached, they've made these available, and they're an amazing set of standards, and we're not trying to replicate those or compete with them. Maybe there are a few areas where we've added a few tweaks, but essentially these are our 12 recommendations. 7 relate mainly to planning and commissioning, 5 relate to routine clinical care, and these are evidence-based. They come from the data, which, as you see, comes from a broad range of sources. But they were subjected, both the report, the findings, to a huge amount of peer review. And thank you to all of you, because there are a lot of people that contributed to this. And I think many of the people that may be online will have had a part to play by filling in a questionnaire or even being on the reviewer or special advisory group. So thank you, because we definitely couldn't have done this without you. And it is your report. I'm just going to bob about a bit in the recommendations, not necessarily presenting them exactly as this order suggests, but I'm going to stick with those in purple because I couldn't give you the whole 12 today. I'm going to try and fix on those that I think are probably most interesting to you at sort of 4:30 on a Thursday afternoon. So you had a really interesting chat yesterday, I am sure, and I'm sorry I couldn't join you for your webinar on ethics and shared decision making. And this is simply the fantastic work that you will all be aware of that was published again 2018 from colleagues looking at the ethical dilemmas and trying to move forward to an understanding about shared decision making. This is not new to those of you, many of you working with this population and in paediatric critical care, and it's become an increasingly challenging issue, as we know, over the last few years. Where's the data from the LTV report, you say? So this is data from the lead clinician questionnaire, looking at around 230 patients that they were caring for during the period of the study, 2016 to 2018. And we didn't want to overload them. So I think it was a maximum of 5 from each centre, and they could have been admitted or they might not have been. They might have been absolutely fine being cared for just in the community. And we were asked them to reflect on whether the LTV was commenced as destination therapy, so lifelong probably, or as a bridge. In the majority, their reflection was that right at the outset, it was destination therapy. So this is just indicative of the decision making, how important the decision making is, because we're not going to necessarily alter the natural history of the underlying condition, but this is life-saving treatment at the time, but a big alteration to that child's life, that young person's life, and importantly their family and the network around them. What did parent carers say about deciding about the starting LTV? They were very free with their comments. This was in various venues, so they could do so anonymously on online questionnaires, and we had a good number returned, around 100 questionnaires returned, and free comments were looked at, and they were just very plentiful. So these are just a small sample, but we also did some focus groups, or they were conducted on behalf of us with the National Children's Bureau. So those were sort of small group discussions with families, face to face or on the telephone. This is very important. I don't think anyone could be fully aware of the life they lead with a trachea child from a parent. They were generous mostly, but of course there will be situations where things seem, certainly in retrospect, to have been done incredibly suddenly and there being no time to ask questions. And then here we have someone who said, you know, they couldn't have done any better. Everything was honest, everything was done that could be done. So what about that little group that actually had a tracheostomy during the study period? And those clinicians caring for those patients relatively recently to the date we published the study were asked in detail what was the decision-making process like. So they were very honest. People are very honest when they complete these questionnaires. In 35 out of 50, it had been clear right then that it was going to be for LTV. So that was the intention. So then we said, was there a clear record of the decision-making process? And slightly disappointingly, just 23 out of 35, it was clear to the clinician who was caring for the child when they looked at the record what the decision-making process had been. Not surprisingly, differences in opinion between clinicians and parent carers. We would definitely have expected that. In only 9 out of 50 cases was written information provided, and we know that that is a standard, certainly in the 2018 quality standards from West Midlands. Was the documentation of an MDT? Again, that really didn't seem to have been documented anyway terribly well in some cases. The implications of ongoing care are a little better. This evidence that it was discussed with parents. Again, maybe you will say only three young people involved in the consent process. Probably not surprising. Many of them were felt to be too young to have participated, and many will have been heavily sedated, or they could have had huge communication issues. But just important to note that it wasn't the young person who could be involved generally in this consent process. But more surprisingly was the fact that GPs certainly were not included in any of the MDT discussions. And when we come to talk about transition of care, then GPs are increasingly seem to be brought in to be maybe the go-to people to try and coordinate care, and they weren't involved at this point in the decision-making process. Recommendation 8 deals with emergency healthcare plans, and I'm presenting this next because this would be, you would have hoped that having commenced LTV prior to discharge, there would be a personal healthcare plan that included information about what to do in an emergency, and that this should be widely shared. It should be absolutely instantly available to the family and to the care team in the community, and that it should be obvious that it exists to us in secondary and tertiary care. So this was recommendation. It's nothing new. We know about emergency healthcare plans for patients with complex needs. They're not. This isn't new currency, but we tried to just reinforce this a little by saying it should be easily accessible to all members of the care team. clearly laid out, as simple as possible, be at least annually reviewed, form part of handheld records, and be and include a fast track admission plan. Here's the use of one in one of the examples from the report. So 150 cases were peer reviewed by a group that Heather's described, people like yourselves sitting around a table. Here's an anonymized example. It's a true story. We anonymize it a bit because we know that, and we hope that parent carers look at our reports. So we don't want to immediately recognise what their own son or daughter here, particularly if there's been some really major upsetting issue. This was an example of actually the good use of an emergency healthcare plan to aid decision making. And the vignettes, as they're called, there are 13 in the report. They draw you into the report because they're little stories. And they help explain things better than maybe lots and lots of tables. And here we have an emergency healthcare plan where things go well. Not all the stories are good news. Some of them are less than good news, but they bring out what's been going on. We asked the admitting clinicians whether they knew about a fast track admission plan. They didn't have to be documented. Did they know that there was one in place? And in about half the cases, there was one in place. A little more in terms of emergency healthcare plans, so that was pretty reasonable, I suppose. Nearly 70%. You'd hope for a larger number. And sadly, the numbers go down because there were a lot of unknowns in here. So that's why we don't get up to 100, anywhere near 150. The rest are unknowns or not documented or not answered. When we asked the clinicians who were looking at the case notes to see whether there was any mention of an emergency healthcare plan or indeed a copy of it, it wasn't obvious to them that it was available. It was very few, in fact, was the reference to it or an actual copy. And you might say, well, these are electronic records these days. People have it on their iPads, or it might be on the hospital system. But actually, it would be nice to know what those plans are, that it's obvious to people when patients are admitted that this plan is in place. Going on to emergency care, which I know probably is an area you're most interested in, we made a simple recommendation about people being able to get care in an emergency anywhere and at any time, because let's face it, they may not want to travel to their specialist centre, and they shouldn't have to do so. So this is the recommendation. These are the characteristics of the 150 patients that were admitted, that we sampled and peer reviewed. So very similar to what you'd expect, complex, maybe multiple comorbidities. Remember, in the overall sample of 3,000-ish, 57% had had an admission during that 2-year study period, and we just sampled 150. But the problems are, as you might expect, a large number of them, the ventilation or oxygenation was causing them problems. It was a problem related to their LTV or their respiratory system. And in the other group, which is relatively large, if you look at that, a quarter of them had problems with secretion clearance or infection or both. So LTV issues or issues relevant to the LTV often contributed to the hospital admission. These were not just routine admissions for something completely different. It was often an issue with their ventilation. Where did they come to? Well, a bunch of places. This is the normal categorization that NCEPOD uses for the sort of hospitals that people go to. So small or large district general hospitals, university teaching hospitals, or specialist paediatric tertiary centres. I think you're probably reasonably familiar with this, but the SPTC is a bit of a clunky one, but it's the big paediatric centres where there's a PICU, where there's an LTV service often. And the younger people are basically travelling further. If you look at that group, 15% of them travelled more than 50 miles to come into hospital because they were going to their specialist paediatric tertiary centre. And these were the younger group rather than the older patients that are more often being looked after now in the university teaching hospitals closer to home. So none of those were travelling those big distances. And I'll go in a further slide to talk about the location of care within the hospital, which will reiterate that. About a quarter went straight to critical care. Don't pass go, straight to critical care, be it paediatric or adult. These are the comments made by parent carers in the main on behalf of themselves and their young people about what it felt like. And these are quite moving, I think, but they ring true. And we'll talk very briefly about the couple of case histories that sort of also bring this to life. Essentially, getting to hospital and feeling like you're the only one who understands the equipment. The GP relying on the main children's hospital for guidance, the local hospital not being happy with BiPAP. And this one, the only time I can really relax when he's admitted to intensive care. So some really important messages here. Here's a situation presented, a true case as a little vignette. During admission, the patient goes to the paediatric ward, they get some physiotherapy, they deteriorate, they need intubating, they go to a general critical care unit for a change of tracheostomy tube. Actually, you know, everything goes okay. But if you were the parent carer in that situation and you saw all this happening and it wasn't a paediatric respiratory physiotherapist and it was a general anaesthetist who came and said, I'm not really very comfortable with this, then you can sort of see where how families feel, particularly if they have recently been discharged from a tertiary centre and they've got used to the idea of people being familiar with their child and their problems and their tracheostomy. This is going to be challenging because the numbers are small still for the district general hospitals, and many of you will work in those and know what it's like to try and maintain skills and competencies and knowledge about the equipment. A lot of these patients had had a previous admission in the last 6 months. So nearly half had had an admission in the last 6 months acutely. As well as this group, there were those that had had 2 or more. And if I tell you that a third of these had had 2 or more admissions and one had had 10 admissions in the last 6 months. So these are patients that are needing to come, some of them, in and out of hospital a lot. And we didn't particularly select for repeated admissions, but this is what we saw. If you've been on LTV for less than 2 years, you're twice as likely to have one of these early admissions and readmissions. So it was 63% of those who'd been on LTV for less than 2 years had to have another acute admission in the 6 months following. Here's one of these readmissions, this one very quickly within 2 days of discharge from a large neonatal intensive care unit, level 3 type unit, need to go into their local district hospital where they're not known and nobody's quite certain what to do. And again, they get intubated in the middle of the night and transferred to paediatric critical care. As I said, kids under 18 are more likely to go to critical care. And this just demonstrates it very, very clearly that nearly half the under 18s, eventually at least, go to paediatric critical care. Whereas when you get to over 18, it's a real minority that go to adult critical care. The quotes are from the in-depth interviews we did with 50 clinicians. They were sort of structured 45-minute to 1 hour interviews. And we also had an online questionnaire that health professionals could complete and leave free comments. And a lot of people did that. That was around, Heather will correct me possibly, but that was over 300 responses we had to that. And as you can see, there are people who are saying, you know what, these relationships are so important. In fact, both of them are basically saying the relationship is really important, but in some cases it's problematic, because there's a feeling that maybe ICU colleagues are not actually particularly used to the complexity of some of these patients, particularly perhaps in general critical care, in adult critical care. But there's pressure on paediatric critical care beds. When you look at this initially, you think, well, so what? This was the safest place for the patient to go. But actually, did this baby need to come in overnight at all? Could it have been managed somewhat differently? The baby's looked after by parent carers most of the time anyway. Could this have been delivered outside the paediatric critical care environment, thus sparing that bed? Overall, the quality of emergency care was not great. So in about 30%, it was felt that there had been good practice. Now, this isn't gold standard practice. This is good practice as judged by the peer reviewers, but it's very much moderated around the room. We know there are hawks and doves in this, and it is definitely not sort of gold or platinum standard practice. If you reflect on a recent previous report on adult NIV that was published in 2017 by NCEPOD, there was only 20% of good practice in there. So maybe you can be heartened by that, but there were areas for improvement. It wasn't all dreadful, but there were areas for improvement either in clinical or organisational care or both. And that was just the peer review data, remember. So why was that judgment made? Well, there were some issues around senior clinical review, and we found that in all the child health studies, actually, that the RCPCH standard, which is common to all the colleges, is that the patients should have senior review within 14 hours of admission, and that didn't happen all the time. More perhaps significant was the fact that there were ongoing issues with identifying who was in charge. These are complex patients, and there may be more than one team involved, but when you're trying to find out who's in charge, it was a problem. It was more of a problem if the admission was not directly related to LTV, but there wasn't actually much difference. It was generally quite difficult. This is another little scenario, and the thing I want to bring out in this is the fact that this was a delayed transfer to paediatric critical care. There were some issues that needed to be improved upon, but inherent in this, there's no joint fast track admission plan. There's no ceiling for the district general hospital care to reach before they get on the phone and ask for help. And then again, when discharge is arranged, there's no involvement of the multidisciplinary team. So how are we going to stop this happening again? And looking at the whole group, there was evidence of community care MDT involvement in only about a third of cases. And so this comment from a consultant nurse is really important. Again, a patient admitted to critical care, the CCG agreed to help with or pay for the care team to get involved with the care while the child is in hospital. That's refused, and the care package falls apart while they're in hospital, and it takes a long time to get them back home again. Importantly, this is really very basic, good clinical practice. We don't expect everybody to be familiar with the ventilator, even though the settings are really pretty much the same across the board with the home ventilators. But I say but actually people are really scared of ventilators, as you know, and so they don't look at the ventilator, and they certainly don't document the ventilatory settings. More surprisingly is there's no documentation of respiratory rate or oxygen saturation in a significant number. So why is that when patients are coming in with respiratory illnesses or problems with their ventilation, or both? So good ventilation care is the obvious recommendation, and it's just about undertaking a standard clinical and respiratory assessment. It doesn't have to be fancy. Undertaking, looking at the vital signs, not being terrified by the ventilator so much that the vital signs aren't recorded, and involving the LTV team. And of course, clinical leadership. Equipment, this is important. I think many of you are sort of very involved in the choice of equipment, but also the ongoing struggles that people have out in the community, making sure they have the right equipment and the supplies of disposables and so on are provided. So we know from chatting to people in the networks that sometimes the big paediatric centres are very much governed by perhaps their colleagues in adult care as to which ventilators are available to provide. We've certainly heard that before. There's a lot of variety available, but actually, as I've said, the modalities are very similar, and people seem to have their favourites. When it comes to working in a district general hospital, or even a large university teaching hospital like I do, I can tell you that our paediatric nurses find it very confusing when they have 4 or 5 kids in the community who regularly come in on different ventilators. So this can be a problem. It's also a problem in that there's lack of consensus, if you like, or at least it would seem to be. There's a lack of commonality on what's provided. So this is the usual categorization into levels 1, 2, and 3 in terms of the dependence on respiratory support. And even those who are most critically dependent on the ventilator don't always have everything they require, certainly according to the West Midlands standards. And you will be aware of this. This is data from lead clinicians who told us what they thought was available. Now, they may be not 100% accurate, but actually there's quite a lot of data here that suggests that there's a lack of commonality here as to what's being made available. And even something as simple and cheap as a self-inflating bag isn't always available. So in case note review, our reviewers also saw that there had been issues around equipment in 20 cases. And again, lead clinicians identified problems with standardization, as we've said, and supply of disposables. And we also had some free comments that are relevant in terms of inconsistency around regarding funding, which does affect procurement. And it's just not standardized, and people can't quite understand why that is the case. And this issue again and again about consumables and simple pieces of kit like suction catheters sometimes not being available readily. But hospitals have equipment issues too. This was a slightly stunning case of a young adult who was transferred across a large city from one large hospital to another because the adult respiratory ward were unfamiliar with the person's ventilator, and they didn't feel comfortable with caring for a tracheostomy either on the ward. And the young man had to be transferred across town to the other hospital to get onto the adult critical care unit there to get somebody who was comfortable with their ventilator and their tracheostomy. So it's not just in the paediatric world that there are issues. And in my own hospital, I know that a very busy respiratory ward, they will take patients with tracheostomies, but not patients on LTV at present. We know that PAN-TEMS is doing some work on transition, and the next NCEPOD study, which is in the planning stage, is focusing entirely on transition. But today we're talking about transition in LTV. So just back to that topic, and this was the recommendation, which very much just falls in line with NICE and the need for developmentally appropriate patient-centred transition planning at age 14. Why did we make this recommendation? Well, it's not just because we went up to the age of 25 and we were told to do it by NHS England. That is definitely not the case. We found that that people were telling us we could do better. So this is based on interviews with health professionals. There were 50 of those in-depth interviews, by the way, and there were focus groups with families. And within their top 3 on both occasions, transition was a real worry to them. What they said it's truly awful. That they're meant, you know, things should be a whole lot better. It's really scary. And there's this huge group that are moving into adult care. And we know that they're there. We know that they're coming, and yet there's no clear, in many cases, no clear pathway. So this is just moving back to health and social care data from their questionnaire. So a large number of respondents to this questionnaire, but only a minority were looking after patients who were they were intimately involved with their transition. So we asked those people to respond to this questionnaire. And it was actually better than I would have expected to say that there was, you know, multidisciplinary teams set up to look at and have ongoing input about transition, more so in the under 18s than the over 18s though. And we see that transition is something that's of interest in the paediatric world to try and get it right. But there are a minority of people on the other side who are picking up the baton. But here, an insightful comment from a consultant respiratory physician this time on the need to get the GP involvement, because they will be working in the locality and try and ensure that they work with the network, they understand the patient's problems and be more well placed to be their advocate. But if they've not been involved for the first 18 years, it's a big ask. So lead clinicians were actually caring. Nearly half of the patients that we sampled were 14 or older. And the numbers go off a bit, but we see that there's a transition that was planned in quite a decent number. However, when you dig a bit deeper and ask about whether there'd been an MDT where a plan had been agreed, the numbers go way down, and similarly a joint transition clinic. And when that hadn't occurred, there was actually no such clinic in half the cases. It just didn't happen. It wasn't set up. So in summary, and we're sort of on time-ish, I think, lots of data, lots of sources. I'm sorry we jogged through that pretty quickly, but we hope there's some ideas out there. I know there's lots going on in all parts of London and the southeast in this area. So we're very happy to take questions. Here are some of the resources I mentioned that are free for you to download and print if you so wish. I'm just going to finally pop this in. So this little boy in the middle with the tracheostomy is Noah, and his mummy and his brother. And Noah's mummy was fantastic. She was on the specialist advisory group. She'd experienced care for Noah in 2 big centres. She was really experienced. She was tapped into all the, there's obviously a very active Facebook group. She helped us get responses from families. And she put together this little diagram, which we put on the inner front cover of the report, because it sort of says it all. And actually, I I think I probably mentioned it at the beginning, Jackie Cornish said to us, she was chairing the independent advisory group that commissioned the report for HQIP. You know, you just need to ask the parent carers and the clinicians, and they'll tell you what the problems are. So we have got a lot of data that helps support this, but I just thought we should give real credit to this lady and her family and all the families. This kid's having a you know, pretty full life, but it's jolly hard work. Thank you very much.
Kathy and Heather, that's absolutely impressive. And I think that was a very comprehensive talk from you, Kathy, to just give us a flavour about the work that you've done, and for us to start thinking around some of the recommendations that you have come up with. I'm just going to open this up to the wider audience. If you are speaking, please turn on your camera if possible to ask a question. There you are, Francois.
Yes, again, thank you, Kathy, for an excellent overview of this overwhelming but very interesting data. I was just wondering, I would, pinpoint one in particular, which is the one around transition. Everything that you've mentioned in terms of respiratory consultants such as myself, I absolutely agree with. But how is it going to be? How are we going to be able to move forward in terms of improving this transition process, because it's pretty chaotic at the moment? And the recommendations that you make are going to make things better. I don't know if it's an easy question to answer, but at the moment it's still very much pretty bad. And I would agree with the comments that you've made.
I wonder.
I've got some personal views about it, because it's been such a I mean, it's been a hot topic for the last 3 NCEPOD studies. So they were on cerebral palsy, young people's mental health, and cancer. All the studies went up to the age of 25. I think Heather will agree with me that it was really, really difficult to get data that we knew was there, if you like, about the appalling journey patients were going through when they jumped off the cliff or whatever, or you know, from the whatever sea to the pond that the report from the CQC talks about. They or from the pond to the sea. It's the other way around, isn't it?
Yeah.
They just it's partly, in my mind, it's the way adult. You know, it's fairly obvious in a way, if you think about it. Adult medicine, and surgery for that matter, is set up in a different way. It's to do with, you know, ologies, and pediatrics has been massively successful in setting up coherent, comprehensive MDT care for complex children and young people, and that isn't replicated on the adult side in most cases. It might be for some of the sort of systems, like, I don't know, diabetes would be an example, and, you know, congenital heart disease, great sort of setups for those groups. But even then, not perfect always. They're not, you know, young people are not likely to be able to fall straight into a young person's clinic when they get their diabetes care, for example. They're going to be queuing along with people much older with, you know, many complications. So it's pretty scary stuff. So that's not an answer to your question. We haven't cracked it by any means in this. We can point to where the problems are, and we can point occasionally to examples where things have been done really, really well, but they're fairly small in number.
I think it's important to engage the primary care and the GPs. As you exactly pointed out, the GPs are key to adult care management. But my own experience in terms of engaging GP in the transition process has been pretty bad as well. You know, they don't want to take one of them, to give you an example, said, I wouldn't touch a patient like that with a batch poll. So this is the kind of reaction that you get. And I understand the, the scare that is scary, because like you said, for 18 years they haven't done anything, and then all of a sudden they need to take on board some complex patients. But I think it's very key, since they manage a lot of adult patients, to engage them as much as possible in that process.
I agree, and that we recommend.
Should we not just do?
Sorry, Mamta. Shall I carry on?
Yes, Kathy, go on. Yes, yeah.
We did make a stronger recommendation in the cerebral palsy report for GP involvement, and there seemed to be certainly our paediatric colleagues that were involved in that cerebral palsy report, both community and hospital based, and our surgeons, because there were some surgeons involved, were fully on board with that and felt very strongly that they'd actually, those of them working in, say, specialist tertiary centres, that said, you know what, we've been a bit guilty here. We might have copied them into letters, but we didn't involve them in some of this decision making. And now we're wondering where they are. And the families themselves were saying, you know what, we didn't go to them for our immunisations, or well, not immunisations, that's a bad example, but they didn't go there for routine care, any routine care, because we were told to go straight to the hospital, or they felt that's what they should do. I would say in a very positive way, but I can't be absolutely sure, that Heather is co-leading, and I'm a little bit involved in the next study for NCEPOD, which is on transition. We've got a general practitioner who works with student health in Bristol, who's been involved with NCEPOD for some time, who's co-leading as a clinician. So that's absolutely amazing. And a week ago, Heather and I were part of a Zoom conference. And I think, Heather, we had 3 or 4 GPs who were really engaged with this problem. So you're right. It's baby steps. It's baby steps forward. But I think we have to keep working on it, because the folder of recommendations on transition is vast, but they have made no difference really. One I can perceive in my time anyway.
I think it would be important to involve them very early on, even before the transition process, to get them engaged from the very start, because then they feel involved. It's very easy for them to say, oh, the tertiary group, a lot of them, the tertiary center will take care of everything, but it should be the other way around. We should get them involved from the start, and then that make the transition process easier.
Thank you. That's really helpful to have that. Thank you.
I suppose that goes for all clinical conditions, and not just the long-term ventilation. I think more and more, as we've got specialised as paediatricians, we've excluded primary care in the care of these children, and I don't think we don't think about it as much as we should. I'm going to put Miriam in the spot. Miriam has been our amazing project manager from South Thames, who's been leading the Pan-London LTV work, and probably could give a few snippets around the work that London is doing. And I know, Francois, you talked about transition, but the other bit was around some of the recommendations that have come through and how difficult it has been.
Miriam's quite busy in the background there. So, Kathy, firstly, it was lovely to actually, I've read the report, but it's so good to hear you speak about it in person. It gives a whole added dimension to the report. So lots of your recommendations we've taken on board. I suppose the one that was most today was around the equipment. So we're looking at how we can reduce the number of different pieces of equipment that are used, because it just makes it difficult. I sympathise with the GP. It's a huge step to try and look after a ventilated patient, never mind if you have 2 that are on completely different, machines, and all the equipment is different. So we're looking at, how can we kind of simplify it as much as possible. And obviously, there's a variation for what patients need, but trying to streamline that process. Some of the things are difficult, but some of the things feel relatively simple. It seems crazy that not every child has a plan when they leave hospital, an emergency plan. So I suppose it's sometimes just about thinking about these things really carefully. So we've got all kinds of groups. We've got commissioning groups, equipment groups, but transition is one area that keeps coming up, and it's not the easiest nut to crack.
I know that Stacey and Sophia, who are the the lead nurses for the network, have been doing a huge piece of work around standardizing education, both from the how DGH is managed, because I think a lot of these behaviors of moving to a tertiary hospital is driven from the lack of comfort within the DGHs to look after these children. So
I think we're using your report a lot, Kathy. Firstly, we appreciated you listening to us, but also in terms of guiding our work streams, there are so many people who are genuinely invested in wanting to make these pathways better for our patient groups. So yeah, hugely appreciate the work you've done, and just to say that we are using that as a guide for many of our project groups, and I hope that if it does get surveyed again in 10 years' time, the experience will be better.
Absolutely. And the other bit that we're quite keenly working is around the commissioning and the support we can give these children in keeping care closer to home with the ICSs. So particularly around how the care for these children are commissioned and respite care for these children, so that we can keep the carers with the child in hospital, which I think is really important, so that the care package doesn't break down.
Do you see what I mean? I think everyone's reached their 5 o'clock limit by the sound of it.
Absolutely. And just before everyone signs off, Madeline, I'd just like to thank you, Kathy and Heather, once again, and Erogen for being amazing sponsors of this webinar, and Teresa, who has been really quiet in the background, who has chivvied us all along, got this day together. So thank you so much, Teresa, Kathy and Heather, and we hope to see you next week at 4 o'clock. Bye-bye.